Hey, good evening. I'm Dr. John Bennett, broadcasting from Nepal. We have another presentation tonight for the ACNS Neurosurgical Students Society. Tonight we have the pleasure of having Nicolay Peev, a neurosurgeon originally from Bulgaria but practicing in Belfast, Ireland. Before Nicolay takes over, let's introduce panelists first. Let's start with Hani. Could you introduce yourself, please?
Hello, I am Hani Tariq. I'm a third-year medical student in Pakistan, and I'm doing a neurosurgical elective under Dr. Salman Sharif nowadays.
Well, welcome, Hani. And Kay, could you please introduce yourself, please?
Hi, I'm Adina Wasim Khwaja, and I'm a final year medical student. I live in Pakistan, and I'm doing my elective with Dr. Salman right now.
Yeah, welcome. Salman, could you please introduce yourself?
Okay, so it's brilliant to be here. Salman Sharif from Pakistan, and I'm looking forward to Nicolay's talk. I know that we do a lot of chatting and do a lot of work together in spine, so let's see what are his concepts regarding MIS.
Yeah, well, welcome, Salman. And Slaven?
Hello, everyone.
Slaven?
Hello, I'm a medical student from Croatia. I am leading the Dandy Club here. I'm also leading the London course and lots of other neurosurgical activities. And I love neurosurgical career neurosurgery. Thank you.
Thank you. Welcome, Slaven. And Joseph?
Hello, everyone. I'm a fourth-year medical student from Dow Medical College. And since Hani has mentioned, I must also mention that I've also done electives with Dr. Salman Sharif in the beginning.
Okay, Joseph, could you please mute yourself when you're not speaking, please? And okay, very good. Okay, Nicolay, welcome, and it's all yours.
Okay, so thank you so much. It's again a pleasure to be part of this neurosurgical TV and to present in front of you today. Can you see my screen now?
Yes, we can. It's very good.
Okay, that's great. So I'm going to talk to you about the minimal invasive spine. I do that for the last 3 years, and this is my passion now. So I'm trying to develop in that area, and that's why my talk will be about the minimal invasive spinal surgery. But before that, I want to give you a few words as a background. So let's say about the spine. The spinal degeneration. Speaking about the spine, we mostly speak about degenerative changes of the spine because this is the most common problem. Many people will not have any problem with the spine despite you go and image them and find a lot of degenerative changes, but this is part of the so-called healthy aging process. But on the other hand, you can go and read a lot of statistics about the spine. For example, the last bulletin of World Health Organization says that all the living now, all that we are on that earth now living will have to meet a spinal specialist by the end of our lives. So it's a huge problem, and it's a lot of work there that we have to do in order to manage all these patients properly. So as you can see, a significant number of patients will have spinal problems, and according to the statistics, the spine is the second reason for sick leave after the flu. So this many patients you will have with spinal problems, and in the majority of these cases that patients are having spinal problems, you will see this same degenerative process that you normally see with the healthy aging population, but that degeneration will go faster and will create problems that you have to treat as a spinal surgeon or spinal neurosurgeon. So why the spinal degeneration is happening? First of all, as we said, that's a normal aging process. You may have some congenital conditions that could contribute for a problem like congenital narrow canal, for example. Of course, your lifestyle is very important. You have to keep a right diet. You have to be physically active. You should not be smoking. Alcohol is also a significant contributor for spinal problems. So all that is important for you to be healthy or unhealthy. This is for your spine, but this is in general as well. Occupational factors, of course, if you do heavy job, that is related to lifting heavy things. Of course, your spinal degeneration will progress faster. Traumatic events also should be considered, and not the last. People nowadays live longer, and they are healthier, so they would like to have unrestricted life. They have greater expectations. So that's why now we are discussing biopsychosocial model of the disease. And the bio, of course, comes for your individual medical profile with all of your genetics and your diseases. Psycho comes for your psychological profile, and social also for your social background. So as I said, nowadays people are having greater expectations. They would like to be pain-free till later. They would like to have completely unrestricted life. There is a great interest in healthcare from patients, from media, from lawyers. So that makes our job extremely difficult, and we have to be very careful because unfortunately we still cannot heal the spine. I'm usually saying to my patients that are having very high demand and very unrealistic expectations that I'm sorry, but I cannot give you an option to get you back to your 20s or 30s. So we cannot heal the spine, but we can treat the spine, and we can teach our patients how to manage their problems. So that's how it started. It started with Mixter and Barr. These two doctors, they were practicing in US, and they have linked for the first time the disc herniation with lumbago and sciatica. And this disc herniation, they realized that actually this could be as a result of traumatic event, or it could be a result of degenerative event. And then the second big step was done by these authors from Germany, Fritz Mager and team. They designed the motor screw and the modern fixation system, and they unlocked the Pandora box. As a result of this, today we have a lot of instruments that we can consider in the treatment of our patients, and sometimes we are very difficult to choose the right option. We have discectomy, we have fixations, we have injections, we can go front, we can go back, we can go combined. So there are many ways to roam, but unfortunately not all the ways lead to Rome. So we have to be very careful what option we use for our patients, because it could be great success, but it could be great failure. So this is usual picture. This is what you will see in many of your spinal surgeries. Usually you go, you open you detach your spinal muscles, you do laminectomy or some sort of decompression, and then you do some sort of fixation, and that's your end point. That's how many of the spinal surgical patients look at the end. Obviously, you could go and have this final result. If you go via the conventional route, you go open your muscles, you put your instrumentation in close, but you could go via the minimal invasive route. You could do a minimal invasive surgery and you still have the same result. So that's why I will stress on the minimal invasive surgery, because I think for me it's a no-brainer in case I can choose if I have to go to the conventional or to minimal invasive, where I'm going. So I want to give you a few words on the concept of surgery. So performing surgery, this is a we need to access a surgical target that is usually deep inside the body. So for that, we need to create a surgical path. We need to create an approach to these surgical targets. Then once approached, the surgical target should be treated. We have to perform the surgery. And at the end, we have to close in order to restore the normal structures. But whatever approach, whatever rules we follow, Of course, we will leave some inactive tissue because we will destroy normal functioning tissue, and we will leave some fingerprints or footprints behind. So that is why we have to consider different treatment options, and the latest is minimal invasive surgery, because the minimal invasive surgery will allow you to follow the basic tenet, the basic principle of surgery, effectively treating your pathology and disturbing or disrupting minimally the normal structures, and like that leaving the smallest footprints. So minimal invasive surgery is a new concept, relatively new concept, that will allow you to do that will allow you to reach your end point, but with only minimal footprints, only with minimal disruption of the normal structures. So, to recap, minimal invasive spine, if we speak about spine, is a procedure that results in less collateral tissue damage, measurable decrease of your mobility, faster functional recovery, while still reaching your intended surgical goal as the conventional surgery. And there is a lot of research now that supports these principles. So the principles that, speaking about the principles that minimal invasive spine uses is splitting the muscles instead of cutting and detaching, like that, creating limited width corridor, which however will allow you still to reach your goal because you're using known and established anatomical planes, and like that you're not disrupting the tendons and the attachments of your muscles, hence giving better result, faster recovery, and long-term outcome. So let's speak about the spinal surgery and minimal invasive. Let's see what options we have in case of degenerative spine. I'm speaking about degenerative spine because treating spine is mostly degenerative. Of course, you will have tumors, you will have other diseases, but you will have trauma. But the overwhelming work for you will be degenerative. So if you have degenerative spine, you normally offer to your patients discectomy. You often offer foraminotomy, you offer laminectomy or any other sort of decompression, and you offer fixation. And in lumbar spine, for example, you have all these options to fix. So you have posterolateral fixation, which could be instrumented or non-instrumented. You have posterior lumbar interbody fusion, you have anterior techniques, you have lateral techniques. Recently, you have also oblique lumbar interbody fusion. So you could access your spine via many trajectories. We usually offer that to treat degenerative spine, and in that degenerative spine, usually we that's a combined term that will designate internal disc disruption, discogenic pain, disc degeneration, segmental instability, also spondylolisthesis, or a combination of all these. Let's see now how we were treating spines, let's say 40 years ago, before the advent of the modern screw fixation systems. This is how a spinal surgery would look, let's say 40, 50 years ago. Surgeons were going, decompressing, then they will prepare the surface, they will put on chips, and they will pray the fusion to happen. Yeah, that fusion was happening quite often, but it was not happening quite often. So that is why I sometimes compare, I think it's easy for you to understand if we compare with cars. So that would be your car if you decide to do non-instrumented fusion of a lumbar spine, for example. You'll reach there, but you may not with that kind of vehicle. So with the advent of the pedicle screws, things are getting better. You can see that this is a car that probably will do the job for you. If you do posterolateral fixation, which is instrumented, this is a good option. It's a standard of care still. You will have high fusion rates. You will have low cost. It's easy to perform. Everybody knows this surgery. But of course, the fusion surface is not great. You rely only on fusion that is happening on the lamina or transverse process. and in many occasions you will have non-union, you will have problems. Then in the beginning of 90s, surgeons developed posterolateral posterior lumbar interbody fusion, which will involve cage insertion, and like that you can do 360-degree fixation. But as you can see here, because usually we perform fixation on previously operated patients, you will have a lot of scar tissue, and that will result in quite significant comorbidity. You see 10% nerve injury. That's quite significant for me, and I think in the modern surgery that is very unacceptable percentage. 10% nerve root injury, nearly 10% dural tear. That's quite a bit. Then we progressed to transforaminal lumbar interbody fusion. You can see instead of posterior lumbar interbody fusion, when you were accessing the disc by mobilizing the nerve root, with the transforaminal lumbar interbody fusion, you're accessing the disc by unroofing the foramen, and like that, avoiding the previous scar tissues, and like that, creating better access that allows you to perform the same 360 fixation with less comorbidity. And finally, only for the last 10-15 years, we are doing minimal invasive fixations and minimal invasive surgery. So why we have to complicate, why we have to go minimal invasive? There is significant data now that will support the following statements: that with the minimal invasive surgery, you will have reduced blood loss, you will have reduced infection rates, you will have reduced postoperative pain, your hospital stay will be less. Some people are discharging even the lumbar interbody fusions now on the same day, so they do us day case procedures. You will have reduced complication rates, you will have reduced costs because you will save from days in hospital, you will save from complications. And then when you become experienced, you will have even less surgical times than the open surgeries. What we can treat with minimal invasive spine? I think we can treat everything because for me, minimal invasive is a concept, is philosophy. So principles of minimal invasive spine could be applied not only for degenerative spine, but also for spinal trauma, for spinal tumors, for infections, and for congenital malformations, or for any other pathology that you think. So with another advantage of minimal invasive is that with the minimal invasive principles, you can treat multiple previous surgeries patients that usually are contraindicated. You can treat obese patients, and the obesity now is indication for minimal invasive. You can treat older patients that you would normally treat with the conventional surgery. You could treat complex medical history patients, and you could consider that for high-performing individuals like athletes or army people that in a normal case scenario need to go and change their employment. But with the minimal invasive, you can get them back to business. So as I said, for me, minimal invasive is philosophy, and that is to apply the principles of surgery that will leave less footprints. With minimal invasive, you can broaden your spectrum of the diseases that you can treat. You can broaden the spectrum of the patients that you can treat. And I think this is the next step going forward. But you cannot start with that. You have to know the general surgery, and you have to know the conventional surgery principles, and then you have to build on going forward with minimal invasive. So I will give you an example. For example, I will give you an example for minimal invasive tilth fixation. I normally perform and use wheelchair approach. Wheelchair approach is a working horse for me for many of my minimal invasive surgeries. As you can see, instead of detaching all the muscles, you go in a well-developed plane, that is the known wheelchair plane, and you develop incision that is only necessary to approach the area that you need to put your instruments. And after you cut your skin, you normally develop your approach only with the finger, so your structures will giving way with finger, and then you rely on your X-ray anatomy instead of on well-known and well-exposed landmarks as with the open surgery. And that is what you see that's what I see during my minimal invasive surgeries. So you will be very familiar with your radiographic anatomy, otherwise you will get lost and it will not be possible to perform your surgery. After the minimal invasive surgery, again, applying all the principles, you get back to the point where the open surgery will take you. You accomplish your endpoint with less collateral damage and with less footprints. Thank you. That was from me. Now, I think, I don't know if you can still hear me. Let me see. I think you can still hear me. So I think next in the program will be Professor Hemislimi. I will not need to introduce him. You should know him very well.
Yes, we can still hear you. Okay. You want to screen share some more material, correct?
Sorry?
You're going to screen share some more material or videos?
No, I think I'm done. That's it.
Oh, okay, so just click on the arrow and that'll get you off the screen share so we can see your beautiful face.
All right. Let's see.
Click on the green. There you go. There we go. Thank you very much, Nicolay, for a great presentation. Well illustrated, simple for the students. And I'd like to open up the floor for any comments or questions.
John, I think I've heard this presentation before, and it's every time he does it brilliantly. I think Nicolay is good, and I think his concepts are very good in this as well. And it's good for, especially for residents. Especially for residents, it's essential to know how to do these difficult surgeries in simple ways.
Yes, I would like to agree with what you just said, because last weekend we had a brief talk with Dr. Andrada from Brazil, and I asked him, could he do a kind of an essential lecture for spinal techniques? And I think this lecture nicely covered it. So it was really a great thing to, as an overview and how can I say, some things which are very important about this concept. So I'm thankful that I attended this lecture. Thank you.
Thank you, Bob. I have a quick question, Nicolay. How much experience does a resident typically get in a residency with minimally invasive procedures? Or does that come later if you do a fellowship?
Well, as I said, maybe 5 years or maybe 5 years ago, this was not part of the training of the residents. Mm-hmm. However, I believe that this is now the part of the normal armamentarium of every contemporary spinal neurosurgeon. So I think this should come during the residency because this is becoming more and more popular. And I think that the residents should be trained for how to perform the conventional procedures. Of course, they have to start with that, but probably at the end of their training, they should be exposed to minimal invasive procedures as well, because their patients will demand that. They will be asking. I have quite often patients when we discuss surgeries, they just come and ask you how we are going to do the procedure. Can we do a keyhole procedure? So this is very important for you if you would like to position you properly, and you have to be possible to offer that to your patients. So I think you cannot wait to start learning that in your fellowships. I think you have to start doing that during your residency, and it's important for you to be part and to be a resident of big neurosurgical centers where all these variety of spinal procedures are done. So you'll have exposure to that.
Yeah, I think I would agree with Nick. Really, what we have done is for our fellows as well and for our residents, the training program, we have included MIS as a basic part. Attending some workshops, conferences on MIS are essential for them as well. And, you know, from their first year onwards, they get exposed to all these kind of surgeries.
Well, you know, we have a resident on the panel, Rakesh. Are you getting much exposure to minimally invasive spine surgery in your residency?
Yeah, we are getting, but not much. But we do a lot of open surgeries. So I was very excited to see this presentation helped me a lot. I would be we as residents in this panel will be very, it will be very helpful for us if Dr. Nicolay Peev has one more presentation with comparison to open surgeries. Miss with comparison with open surgeries, one more presentation in detail will help a lot. As this presentation was very good. I have two questions. Like, sir, can you please tell me which are the good places where we can have a good observership or fellowship for Miss after you have a good exposure of open surgeries, open spine surgeries?
Where are you? Sorry, Rakesh. Where are you located?
I'm from India. I'm a neurosurgery resident from India.
Right. So unfortunately I cannot tell you where exactly which center is performing minimal invasive procedures, but normally from what I see, the Indian neurosurgeons are presenting very good techniques and very good presentations. You guys there have very big numbers, so I'm sure that any of the big spinal centers should be possible to give you exposure to that, because minimal invasive surgery is becoming now a standard of care. I hope you got my message from my presentation that for me the goal was not to teach you how to do that. For me, the goal was to stress that this is a contemporary care now. This is something that you have to think, and you have to think for minimal invasive as a way of treatment, as philosophy for your patients. The way that will allow you to operate your patient and to achieve the end point by disturbing less normal structures. That's how it is. And I'm sure that this is standard of care in India, that you can see that in many places. Any big center should be possible to give you that exposure.
Okay. Thank you, sir. Thank you. Thanks a lot. It was a very nice presentation. Thank you.
You know, Nicolay, an older neurosurgeon that wants to start doing it, do they take courses? And if so, how long do those courses last to kind of learn how to do minimally invasive spine surgery?
Yeah, of course, you have to go and see some courses. You have to go and see first a few surgeries. It's going to be the normal way how you learn any new technique. You have to go and see first. You have to be aware of the anatomy. You can go and attend a few hands-on courses. You do a few. Let's say you start with minimal invasive approaches. You start with minimal invasive pedicle screws. Then normally you go and attend somebody that's doing it. Sorry, there is another. Yeah. So that's a standard for any new procedures that you learn. So there is plenty of courses now that's ongoing, because becoming more and more popular, and you can learn different minimal invasive techniques. You can learn endoscopic techniques. You can learn percutaneous techniques. All that is now just that's happening now. People are progressing to that, and this is the next step of how we treat our patients.
Very, very good, Nicolay. Okay, any closing comments or questions from any of the panelists?
Can I speak?
Go ahead, Henny, go ahead.
It was a great given that it was a Sunday, enjoying these presentations is actually a feat for me, and because they were actually really interesting. So thank you to all the people who took out time to, to teach us. Thank you.
Thank you, honey. Hope you become part of the community. Okay, very good, Nicolay. We'll wrap it up, and I hope this is one of the first of many presentations that you do in the future. So
definitely, it was my pleasure to be part of that. And so I think now I will step back and I'll leave the chair to Professor Kenneth.
Okay, very good, Nicolay. He's in the next room to where I'm at.
He's just sitting next to me here, and he's waiting to start and to deliver his interesting lectures.
Okay, I'll formally end this one, and then we'll start that one. So thank you, everyone, and good night.